G'day and welcome to today's episode of Endo Untangled. My name is Alecia Macrow. I'm a GP with a special interest in endometriosis and pelvic pain, and I'm joined as always by Cherie Noble, accredited exercise physiologist and Thrive Endo Navigator nowadays. And today we have a special guest. We are joined by the wonderful Dr Jess Floreani, who is a specialist women's health general practitioner, director of Aware Women's Health here in Adelaide, and has spent quite some time with our local sexual health clinic as a LARC coordinator, which we'll talk about a bit later, and medical educator. Dr Jess Floreani, thank you so much for joining us today. We really wanted to dig into some of your knowledge about women's health and endometriosis and contraception and hormonal management of periods and endometriosis. Can you tell us briefly a bit about your background in looking after women and the work that you do?
Yeah, I'd love to. So I've been a GP in Adelaide for 18 years or so, and have worked a lot in the women's health space, and now that's primarily all I do. So my main practice is women's health only. So I work with amazing gynecologists, psychologists, pain physician as well. We've got a good network of physios, and also had a background in working at Shine in a number of different capacities. So I was there as a clinician in clinic, and then have always been involved in medical education. And then in most recent times, I've been the LARC coordinator. So that's just a fancy name of talking about implantons and IUDs. So I managed and coordinated all the training for doctors in that space. And in that involved a lot of patient education and education to nurses, medical students, and other allied health. And usually there's a few different organisations and committees so that you're involved in through that as well. I've more recently, so I've stepped away from the Shine role and left that in some exceptionally capable hands. And more recently doing a lot of work. I'm currently the board member for the Australasian Menopause Society for SA and NT, and still do a lot of work in terms of education with various different platforms as well as just my clinical work.
Absolutely the right person to have on to be talking about this important topic. So with that background, it's incredible to have you on to talk about the menstrual cycle and the role of, let's start with how estrogen and progesterone work and what a menstrual cycle looks like in terms of then how we think about endometriosis and what that role is in terms of the cycle. Do you think that's a good place to start, Alecia?
Absolutely. And what I wanted to suggest to anyone listening at home, whether they're a practitioner or a patient, someone who's struggling with endo or thinking about what they might do in terms of management, is to bring some curiosity to this stuff. We all kind of know how the menstrual cycle works, or many of us do. We've all had that lesson in year 8, 9 biology, but it's such a complex an interesting bit of science, and the way that the medications work are also really interesting. But I think there's been so much that social media and just even the general media has been flooded by these sort of blanket ideas and statements which just miss all the nuance.
Yeah.
And women just get lost in all of this just garbage, to be honest. And so that's what this episode's really important to me, just to kind of go, all right, how about let's just put whatever we've seen or whatever we've heard just to one side for a minute and just bring some really genuine curiosity. So with that in mind, Jess, hopefully you can distill a whole lot of scientific information. No pressure. But let's start with the menstrual cycle, particularly talking about the role of estrogen and progesterone.
Yeah. So when we're talking about, whether it's fertility, when we're talking about, why we're getting bleeding or why we're getting particular symptoms, it is important to understand why we're offering certain types of treatment, because it comes back to, well, why does that work? And, people get the curiosity, I think, when they're more interested in fertility, but not necessarily when they're looking at trying to manage a particular problem that they're having with their menstrual cycle. And yet we probably all get taught it, but let's face it, not many of us probably were listening in year 8 and 9. And unless you're sort of delving into that space, it's probably something that you just take for granted. So I think essentially what is happening in a normal menstrual cycle is we're getting the hormones from the brain, the anterior pituitary in the brain, and the hypothalamus are then coming down in a pulsatile manner, and they are stimulating the ovaries. So think about it as an access from the brain down to the ovary. And so the ovary is then getting stimulated by these hormones to start recruiting follicles. And those follicles get recruited, and a few of those are getting recruited, through the cycle. And then one, sort of wins that race and becomes what we call the dominant follicle. Okay. And then as that dominant follicle is developing, we start to see a rise in estrogen and then progestogen in the middle of the cycle. And most people remember vaguely that around ovulation, like, oh, yep, I get that estrogen surge. Everyone feels amazing. We all feel good. It's a happy time of the month, generally speaking. And then if nothing happens, so that egg that's being released doesn't get fertilized, that follicle then dissipates as a corpus luteum, and the estrogen and progesterone levels drop down. Okay. And then as those levels were rising, you're seeing a concurrent thickening of the lining of the womb. And so that's building up and building up. That's our endometrial lining. And then again, as those hormone levels drop down and we don't actually then have a fertilized egg, we're not pregnant, then that drop off then causes that shedding away of the lining. Okay. And that's our period, right? And that's that end stage, that luteal phase that we see. And then that sort of goes away, and then the cycle happens again. And so that's really a short version of your menstrual cycle and what's happening.
And I think it's important what you mentioned around how you feel in those times.
Definitely.
Yeah. So can you just talk a little bit more about that? Like, so you feel good at, some points, but then, that where we hit those moods, and how does that correlate with
That's right. So we often talk about luteal phase being, potentially challenging. So, often, there's lots of jokes, there's plenty of memes around PMS, about how we feel during that time. And that can be, sometimes it's the hormone level per se, so both estrogen and progesterone, and sometimes it's actually the fluctuation in the hormone level that can trigger off some of those symptoms. And, they're very stereotypical, can be, things like bloating, breast tenderness, mood changes, irritability, poor sleep, fatigue. Particularly women notice, they just don't have the energy for doing what they're doing, gym, workouts, things like that. They're noticing they can't, do as much as they were in that stage. And that can be a variable length of time. Some women get it quite significantly just for a day or two prior to their period. Others, it can actually last, quite soon after ovulation for them. And so really then for half of that cycle, they're really struggling with different symptoms, and they may vary. So a lot of women find that mid-cycle time, that peak with a high estrogen level, they're feeling quite good. They've got high energy, they've got better focus, and, feel as though they're, more confident on top of the world, and then that changes for them. And not all women experience that either. But that's sort of why it's that change in the hormones that we see in that luteal phase that can contribute to that.
So just a couple of things to pick up on there. Well, in fact, there's so many, and we're going to have this all day. There's so many different places. It would be nice to go with this conversation. Yeah. But in terms of where the actual hormones themselves come from, so both estrogen and progesterone are arising from the ovary in different ways. So estrogen's being made, particularly in that first half of the cycle, in a big way, that's coming from the ovary itself. And then the progesterone component comes from where the egg cracked from.
Cracking that egg open. When the egg cracks open.
The egg shell is where the progesterone is coming from, which means if you don't ovulate in a cycle, if you have an anovulatory cycle, you're not going to have any progesterone that month, essentially.
And so that's why we often see in anovulatory cycles that people don't necessarily have a period, right? Because they're either not ovulating, so they're not getting that development of the endometrial lining, which is being stimulated by the estrogen rise from the follicle being, and developing. And then they may not have that shedding away of the progestin. They don't have that rise in progestin that we see, after ovulation, and they may not shed away. So you can still have a period with an ovulatory cycle, and we see that in patients with PCOS, but we also see the flip side, and that those periods often don't seem to be as normal, I say that in inverted commas, as their regular cycles. They often might be light, spotty, bit haphazard, come and go for a few days at a time and things like that, or they just don't have a cycle at all because they don't have that natural variation and change in their hormone levels.
So if we think about the endometrium itself, the actual endometrium inside the uterus, that is proliferating and growing.
Yes.
Stimulated by the estrogen.
Yes.
And I often think about the progesterone component, which is that bit that comes after ovulation, is going to be stabilising and perhaps developing the endometrium. How do you think about what the progesterone does?
Yeah, so I see it as a stabilisation. If I think about how we use progestins, it's to try and help stabilise the lining and keep it sort of relatively thin. So, the estrogen is what is causing the proliferation, the building up, the thickening of that lining, and the progesterone is what we're doing to hold and stabilise where it is.
Yeah. An important concept that I bring up with my patients is that what you have when you have a period, that endometrial lining, it's not just blood. It's active, live tissue. It's got little mini blood vessels in it. It's got stem cells in it. It's actual tissue. And when the progesterone tanks, if you haven't had a fertilisation, that lining sheds.
Yeah. So I think it's, when you're trying to explain what's going on, it's quite relevant when you're trying to, and we go back to treatment options as to taking away that understanding of, some people go, well, isn't it just building up? Where's it going?
Yes.
What's happening to all this bleeding? Like, it's got to go somewhere.
Yes.
And we're like, okay, well, that's how these medications can help work. It's just not building up. We're not proliferating the same way, that same active tissue that's then going to shed away. You're right. It's not just, it's an active dynamic process that's happening every month because this is live tissue.
Yes. And it's unbelievably elegant when you look at it.
Oh, it's amazing.
Yeah. Although, as we've talked about in other podcasts, this process was never intended to be something that you do 450 times in your lifetime.
No, it is. And that's a real challenge. And I think it's really important to try and get our head around that. We weren't living this kind of a life that we live now many, many years ago. And physiologically, we are designed to, be having babies, to be pregnant, to be breastfeeding, and to be, without a period for quite a long time. And so it is really challenging going back to the whole natural state and things like that. And that's not to say that, we can't manage, and a lot of people can manage with really regular periods and they're okay. But it is also okay to understand that we weren't always designed to have a period every single month for the rest of our life.
Absolutely.
And particularly when things aren't going as well as they should be.
Yeah.
I think that's, we've talked about sort of cycles and what's happening, but what happens when things go not to plan and we're starting to get really heavy bleeding and lots of pain and the things that we see with endometriosis and pelvic pain.
Yeah.
And can you talk to us a little bit around that with what we're trying to achieve? Like what's actually going wrong, and then we can talk about maybe the what to do about it.
Yeah, so I think, there can be a number of things going wrong. As we talked about, you can have anovulation in your cycle. You can have endometriosis. You can have adenomyosis, which might be contributing, things like endometrial polyps. There's lots of different, conditions and other, hormonal metabolic conditions that can contribute to changes in cycles as well. So it really depends on what are the issues that you're having and why. Now, sometimes we don't necessarily have a really good reason. We might just be, okay, you've got, you're a heavy bleeder. Mum was a heavy bleeder. My sister's a heavy bleeder. Okay.
Super menstruator. That's what I like to call some of my patients. Super menstruator.
Yeah.
If the superpower nobody wanted.
Yeah. they're exceptional at it.
Yeah.
Exceptional at breaking through all the things that we try.
Oh, absolutely. So just to pick up on that, Cherie, let's have a think about, particularly in terms of endometriosis. So we've talked about what the endometrium's doing during that cycle. If we think about endometriosis, which is similar tissue, that might be sitting somewhere that's obviously not in the uterus, somewhere else, perhaps in the pelvis. What's that type of tissue doing through that hormonal cycle?
Yeah, so trying to explain to patients, the endometrial tissue doesn't know it's not in the right spot.
Yes.
It doesn't know.
Yes.
It's there, it's hanging out, it's just doing its thing.
Yes.
And so it's responding to those hormones exactly the same way. And so, in a very basic way, it's proliferating and then it's potentially shedding, but it's doing that in the wrong spot. So it's doing it in a spot that the body doesn't accept as, normal. And that then triggers off, as, you guys have discussed on numerous different podcasts, all those neuroimmune and mediators that then happen as a result of that. Because that endometrial tissue doesn't know it's sitting outside the uterus.
It's like Mr. Magoo just kind of innocently driving around the pelvis, causing all sorts of mayhem.
Yeah,
without
really innocently.
Yes,
yeah,
innocently. Yes,
it's trying to find where it belongs.
Yeah,
it doesn't.
Yes, but that chaos is real. So the bleeding sets off an inflammatory process, and that inflammatory process is the body's way of trying to deal with this problem that shouldn't be happening. You have a cycle, and the progesterone tanks, and off goes the endometrial shedding, if it's in the wrong spot or not. Off goes the problem again. And that can be where we see people getting worse and worse and worse over time.
Yeah. It's important to understand, though, I think conceptually that, sometimes people think, well, if that endometrial tissue is in the pelvis, am I just bleeding into my pelvis every month? But it's more at a microscopic level. So you do see the nodules and you see that sort of stuff, but it's not like you've got a pelvis full of menstrual blood that, you're trying to deal with. So I think that's important to understand that it still causes the same physiological changes that we see everywhere else.
Yes.
Yeah.
So I think that's hopefully a good segue into, okay, what are we going to do about this problem? And one of the first weapons we have in the arsenal in medicine is, okay, how can we use the hormones that we have at our disposal, in terms of most of them developed for contraceptive purposes, not all of them, to try to manage that sort of that problem. Could you talk us through how a combined sort of contraceptive, like sort of with estrogen and progesterone, might help with something like endometriosis?
Yeah, so I think, it really depends on all the things that we're trying to manage as to what approach you take. Because as I'm sure you guys have discussed before, there's a number of different ways that you can try and manage this. And, it's important to understand that a lot of people come in and think, oh, they just put me on the pill, but
yeah, we do hear that a lot.
Yeah, if you understand why and the concepts behind why, which we've just tried to explain, then you realise that it's not necessarily a Band-Aid measure that people think it is. They're just like, oh, I'll just fob you off by giving you the pill and off you go and you'll be fine. There is understanding and science and reason behind what we're trying to achieve. And so, giving the pill, in whichever form there is, now whether that's progestogen-only or estrogen and progestogen, can be really helpful. And it can additionally, control some of that bleeding that we might be experiencing that's difficult. And that's often the first step, in trying to manage endometriosis is, okay, there are lots of different ways we need to approach this. There are lots of things that are going on. But that trigger point of the bleeding and the cycle itself, if we can't control that, we're just doing everything secondarily. We're then trying to deal with the musculoskeletal side, the neuroendocrine side, the sensitization, all those things that are happening because we're bleeding. So let's try and address that first, and then we can subsequently start to address everything else. So you can use, obviously we've been talking about progestins a bit. So just progestins really, or progestogens when we talk about them, are the synthetic version of a progesterone. So progesterone is what we have naturally, okay?
What comes out of the cracked egg.
The cracked egg, yes.
Yeah. So when we talk about progestins or progestogens, that's what we mean. Okay, we're talking about the synthetic ones that we use. And there's lots of different ones. So there's not just one, and they're not all the same. And so we use them in slightly different ways. And we dictate a little bit what we can use because they come in, obviously, formulations that are either on their own or they're combined with an estrogen or an estradiol, in the form of a contraceptive pill, which is what most people are familiar with and come across. And whether you understand that they're all different or whether you think they're all the same, we hope we'll try and undo a bit of that today. So a little bit of history about what's worked for you is really important. So would I use a combined contraceptive pill with everyone? No, I wouldn't.
It does sound very individual. So it depends on, symptoms, history, what the actual problem is.
Yes.
It's not even though we're talking about the pill or whatever, it sounds like depending on your situation is going to dictate where you head with a lot of these solutions. Is
Absolutely.
that right?
Yeah, absolutely. And what your risk factors are. Do we actually need contraception with it as well? Okay, because not all of these options are contraceptive. A lot of them are, but not all of them. So do we need contraception? Do we have any risk factors where we wouldn't be using an oral estrogen? So that's things like clotting risk. If you had a PE or a DVT, it's a strong family history of your clotting disorder. Do you get migraine with aura? Have you got high blood pressure? Are you, overweight, obese? Are you a smoker? So any of those things we go, well, actually, we shouldn't be using an oral estrogen. So then that takes out a number of options. Sometimes the addition of the estrogen can stabilise the endometrium a little bit. So for some people, it's the progestogen that's doing the heavy lifting in terms of contraceptive effect and effect on the endometrium. But occasionally we might need to add in the estrogen for some stabilisation for people. If we're getting a lot of breakthrough bleeding and things like that, that can actually be quite helpful. Or we need really good control. So we want really good control. I'm a competitive swimmer. I need to really know when I can have this a withdrawal bleed. That's what I call it. It's not a period.
Yeah.
It's a withdrawal bleed. And I need to be able to schedule that. Okay, well, we need something that's really stable for you. And that's still going to take some time to work that out about what one suits you and what fits. But we might use a combined oral contraceptive there with the estrogen as opposed to a progestogen-only method at that time.
So it might be helpful just to kind of think about, all right, so we thought about what a cycle is, which is, I guess, a naturally occurring cycle that our body's managing. If we were to add a combined contraceptive, so that's one with both estrogen and a progestogen usually, what's happening in the uterus, in the pelvis at that with that sort of medication?
So with any of the oral contraceptives, what we're doing is we're stopping the LH and FSH release from the brain that's signalling down to the ovary. So we're calling that ovulation suppression. So that's how most, not all, but most contraceptives work, by suppressing ovulation. Okay, so we are stopping that hormonal cycle from occurring from the brain down to the ovary. So we're cutting that off there, and that we are then giving you a more even, just steady state of the estrogen and progestogen. Okay, so we're not getting the rise and fall. We're not getting ovulation occurring at all.
And what are the benefits of that for someone who's experiencing endo and pelvic pain?
So that we're stopping the proliferation.
Yep.
Yeah.
So not getting a lining.
Yep. So we're not going to build up that lining wherever it is, okay, uterus or outside. And then we're not also trying to shed it away when we get the drop off. Okay, so we're trying to keep things fairly stable and steady. Most of the estrogen is around about that early follicular stage level, so it's fine, it's okay. But we're trying to stop that trigger for the cascade that happens from having a bleed. And
so I've heard it explained that some of those combined treatments, it's like you can be bleeding monthly when you have that withdrawal bleed, and we should talk about that in a second, but you're not usually ovulating.
No.
Because the ovaries, through the medication, switching off that brain signal is sort of putting your ovaries to sleep temporarily while you're taking the medication.
And is that okay? Is that okay for the ovaries to be asleep?
Yeah.
Yeah.
It is. It's fine. So we're not, we're not suppressing them forever, but we are just stopping that hormonal cycle. So it's like when we're pregnant, right? We don't have that hormonal cycle gets switched off, through the feedback into the brain from the hormones that are around in pregnancy.
Okay. Which is like you said before, that's how we're made or designed to not be having those like periods and those cycles.
So keeping the ovaries quiet.
They're just having a little rest.
They're just having a break.
Hard.
Yeah. And yes, even though we might have a withdrawal bleed where we take those hormones away, so those sugar pills we all talk about, which we are a little bit of sugar, okay, we're just taking those away. And so the drop-off then in the hormone levels triggers a withdrawal bleed. But that's why often those withdrawal bleeds when you're on something like the combined pill are often lighter and less painful anyway, because we're not getting the same proliferation that we're getting in a normal cycle.
So what are you actually bleeding when you have a withdrawal bleed? Like what's actually coming out? Is there endometrial tissue there?
Yeah, so you're often still, bleeding away and shedding away that endometrial lining, but it's just, stabilised to a degree, depending on how effective we're doing that.
Yeah.
Right? That really depends on how we're managing the endometrium with whatever pill we're using or whatever hormone we're using at the time.
So if the combination's not right for that person.
Yeah, they're going to get irregular shedding. They're going to get, not very good control of their periods and that lining, and it's going to be very haphazard. And we're like, okay, this is not working for us.
So does that mean they're on the wrong pill? Not the wrong pill, but maybe not the most effective for them?
Yeah, it means we might need to look at what we're doing because not all of the pills are the same, okay? And so it's really important to know what you've used in the past and for someone like myself to understand, okay, but what happened? Okay, because often you hear, it's like, oh, I was on the pill, it's no good for me. And it's a blanket statement.
Or I've tried them all.
Yeah, I've tried them all. And I've tried...
But that was maybe like 15 years ago.
All the ones that are actually the same but just different names.
Yeah.
Yeah, can we talk about the names? Like what are you prescribing and what's the understanding of what these are?
This is a real bugbear of mine. I just think that the naming of some of these pills is so patronising to women.
Yeah.
For example, you would never have a men's pill for, say, erectile dysfunction that's called Bob or Jerry, or what are you taking? Oh, I used to be on Jerry and now I'm on Brian. And I just think I really don't like it. So what I'd really love for us to do is, yes, we'll talk about the names because that's how people know them.
Yeah.
But what I'd really love people at home to be thinking about is what's actually in my Clara, in my Zoli, in my Diane, Brenda, Karen, Jessica, whatever, because those names don't tell you anything about what's in them, do they? And we will have people who say, yep, I've taken Monofem, I've taken Microgynon, I've taken Evelyn, I've taken this, and they're all the same. They've all got...
So they think they're trying different names.
They've got
but
different
we're not.
names.
It's just, because it's a different name doesn't mean it's a different
so
ingredients.
Yeah, so most of the we're talking about the combined for now. We'll come back and talk about progesterone only in a minute, or progestogen only in a minute. But most of them are ethinyl estradiol, so that's a type of estrogen.
Yeah.
Could you tell us a bit about ethinyl?
So it's just I suppose more synthetic estrogen, that's been around for a long time and it's still absolutely fine. And we have that in different dosages in different types of pills. So majority of the pills will have 30 micrograms of ethinyl estradiol in them. And we've got a huge amount of, data and research into ethinyl estradiol. There are some low dose pills that will have 20 micrograms. And then there are some of the higher dose pills that we refer to that will have 35 micrograms. And it's important to know because it also refers to sort of, VTE risk and things like that for some people.
So that means clots in legs and lungs.
And also perhaps the dose often of the progestogen that's in those is often, if you're using a lower dose estrogen pill, you'll often have a lower dose progestogen in it. And so that might be relevant too for, so you're getting some breakthrough bleeding, or we can't skip through our period, which we really need to. There's a reason. Maybe we just need to adjust the dosing. So we're tolerating the pill really well. But the other option for some of the pills, we've had a few more recently that have had estradiol. So estradiol is the estrogen that we have naturally in our body throughout most of our reproductive life. We use estradiol primarily around, menopause treatment in menopause hormone therapy.
It's like body identical. I use the term for
body
estradiol.
identical. There's only a few pills that have that in it. Do we have to be using that one as opposed to ethinyl estradiol? No. And that gets quite nuanced and individualised, I think. But for the majority, from a contraceptive point of view, for bleeding control point of view, with the progestin, it's absolutely fine to be using.
So that's our ethinyl estradiol. So be nice if we had a good way of remembering that, but that's just ethyl. It's ethyl.
Ethyl.
Yeah.
I like that.
Most of them are ethyls.
Yeah.
But there's some estradiols out there, but mostly ethyl is the estrogen component. And again, if you're on a combined pill, pull it out and have a look at what's in it, and it's probably
What are
ethyl.
some of the names?
All of the pills, really. All of
them.
the ones we've talked about are going, except for Zoli.
Zoli's got estradiol.
Nextstellis is a different
actually
type.
Yeah, that's actually E4.
Yeah.
So that's estetrol,
Yes.
which is actually relatively, well, it's actually been around for a very long time, estetrol, but in a commercial sense and actually being able to utilise it, it's only relatively recent that they've been able to use E4 in a combined pill, and that's in Nextstellis. So that's slightly different as well. Again, body identical, but interestingly, E4 is really only around in the fetal liver.
Yeah.
So it's, so we really only see it when we're pregnant. But it is still a, body identical estrogen as well.
Yeah. So most of the others, your Brendas, your Evelyns, your Levlins, microgynons, they're all going to be ethinyl estradiol or ethyl.
Ethyl.
But the progestogen component, there's a number of different ones of those. And that's what I really hope that if you're listening today, you can take away from this podcast, is that they are not all the same.
No.
And we can use that to our advantage, and we can also help to understand if we've had issues in the past. We also need to look at the context of when they were used as well, but also look at, okay, what have I had? And if I have had 4 different pills that all didn't agree with me, but they were all ethyl and, say, levonorgestrel, which is one of the main progesterones that's used, it's like, okay, well, let's not do that combo again.
Yeah.
Let's look at something else.
Yeah.
Let's do something else. So we might as well start with levonorgestrel, because I think that's one of the main ones. Tell us a bit about that one.
Yeah. So look, levonorgestrel has been around for a long time, and it's like all of the progestogens have their place and they're all really good. And often it's about starting off, stepping in, and just seeing what happens. So I always ask patients, what have you used in the past? And that's why it's really important to look at what you've used in the past. A lot of people don't know. They're like, oh, I've just used all these pills. I'm like, okay, well, let's try and tease out a little bit and just start throwing out some names, and a few might stick. And so it really is trying to get an understanding of what works and what issues they had with it. Levonorgestrel's been good because it's been available on the PBS as part of a contraceptive pill for a very long time. It's also available as a mini pill, like the progestogen-only, as well. It's generally, pretty good, pretty well tolerated, and can be, quite useful for bleeding control as well. And it provides really effective contraception. So I think as a starting off point, a lot of people have used that because it has been on the PBS and available, and without it being too expensive for such a long time. So
it's often a good starting one, isn't it?
It's a starting point.
Garden variety.
Yeah.
Ethyl and Levo, whatever we want to call it. If we can come up with a better name, that would be good. But.
Yeah. So often, it's like, okay, well, I haven't used anything before. Okay, there's no reason not to. If we can use this one and it works really well, wonderful. Okay, great. So start off there.
Yeah. It's cheap, it's simple.
It's simple, and most people do okay.
Levonorgestrel is also in the Mirena.
Yes.
And we'll come back and talk about the Mirena as well.
Yep.
And a similar one is also in the Implanon. It's not quite the same, but
it's a little bit different. It's etonogestrel, but sort of similar families.
Same family.
Yeah.
Brothers and sisters. Right. So again, I'm similar to what you're describing, Jess, in that if I see a 17-year-old who wants to come in and start on contraception, we talk about different things. We work out if she's got any issues why she couldn't have a combined pill. Often I'll say, hey, let's start with a garden variety pill. And I'm thinking ethyl, ethinyl, estradiol, and a levonorgestrel, like a Levlin or an Evelyn or something like that. That's a good place to start. So that's the first one. Second one is norethisterone. Norethisterone. Tell us about norethisterone.
Yes, I quite like norethisterone as a progestin, because I think it's good. It has quite good bleeding control.
Yeah, so it's a good stabiliser.
Yeah, we have had a few issues with getting it, like a lot of things over the last few years.
Yeah.
So that has been a little bit of a challenge. But the advantage we've got with a couple of the norethisterone pills is that we have option for dosing. So you can use a 500 milligram norethisterone pill. And if you're tolerating it well, so you're managing the any side effects, everything else seems to be going okay, and you're not having issues, but you're still getting some breakthrough bleeding, it's one of the only pills where we can go, I'm going to keep everything the same, but I'm just going to increase that progestin dose a little bit within the same pill, and you can often get better bleeding control that way. So it's nice because you've got a bit of flexibility.
Yeah, to help stabilise that endometrium again.
Yes.
And stabilise and thin the endometrium. So we're talking about Norman, aren't we? So that's one of the main ones.
Norman 1.
Yeah.
Yeah, is it's a slightly higher dose, but estrogen dose stays the same.
Yeah. So Norman stops your bleeding. Norman and Ethel together are quite stable couple. Yeah. So, and you can get one which is stronger than the other. So there's Norman 1, which has got double the progestogen as the ordinary Norman.
Yep.
It's Norman on steroids.
Yeah.
Yes, he's a strong Norman. But strong Norman's been hard to get.
Has been hard to get. Yep. So that has been a challenge because I've had a lot of patients who, have done well, and then we're like, okay, now what do we, what do we do? It seems to be okay at the moment, but, supply issues have always been a bit of a challenge for MHT as well as hormonal contraception the last couple of years. It's been a bit difficult.
Yeah, and norethistérone also is available in a much bigger dose in something called Primalat, which is the best friend of the GP if you've got someone coming in with really heavy bleeding, say it's perimenopausal bleeding or something like that, which is just giving someone a big whack of good old Norman, which can stop their bleeding.
That's right.
Yeah. So we've talked about...
And that's usually taken in conjunction with a pill as well.
It can be, but it doesn't have to be. So you can give someone a Primalat, which is just a big old whack of norethistérone, which will often stop bleeding if it's a problem.
I think what I'm picking up on here is there's so many nuances with this. Yeah. It's not just here's the pill.
Yeah. Now, Cherie, you're our non-doctor at the table today, a very important part of the table in that way. Are you following what we're talking about?
I think mostly.
Okay. Yeah. Anything that we've caught you on? Because if you're caught on it, other people are going to be caught on it.
Well, it's a lot to digest, isn't it?
Yes.
There's a lot of different options and there's combined pills and then there's progestogen-only pills. Correct. And then you can take the combined pill just on its own, or you can take a combined pill with a...
Well, we haven't even talked about Bill yet.
Bill, I know, Bill. I'm like getting my Bills and Normans and Roberts all confused here. I think it's probably good just to summarise that it is that there's, if you can just succinctly just summarise where I was going with that, that'd be great.
I think the best thing you can do is know what you've been on in the past. It's understand that it is nuanced, it is individual. And so don't necessarily feel as though you're being dismissed by saying you need to go on the pill. There is reason and rationale behind the choice, even though it may not appear that way to you.
And I think because you guys are so good at what you do and so knowledgeable and so in depth with your experience, you can make these quick decisions that seem like a quick decision.
Yes.
But it's actually years of experience and knowledge that you're able to go, right, here's all these scenarios and this is what's going to be best for you. And I can do that really quickly because I'm so good, basically.
Yes, but a good clinician's going to bring their patient along with them, aren't they? But that is one of the reasons why I really, really wanted to have today's podcast to really break this stuff down, because we don't always have time to discuss this in so much detail.
Yeah, and I think it's tricky.
Yeah, and I think the things that we hear is it safe, and is it not just is it safe, but is it healthy? I think there's just so much concern around, should I be doing this? Like it's natural, it's, and we have addressed that with how we're biologically made up and what we're designed to do is have lots of babies and breastfeed, so we don't have those, probably a menstrual cycle for a decade or so.
Yeah, that's right.
But I think we just want to reiterate that.
Safety, and also you mentioned the word synthetic a few times, which comes up to me in clinic as well. So I'd love if you could kind of just comment on some of those issues.
I think it's there's a lot there does get a lot of concerns like, well, I'm putting this other stuff into my body, and should we be doing that, and does everything have to be body identical to what we're doing? And we do have some of those options around, and we don't have to do this either. But certainly, the option is there, and I think it's quite safe, for the right people to use these hormones when our body is not helping us out.
Absolutely.
If our body's not doing the right thing by us and it's causing more damage and it's causing more problems for us, and we're not attending school, or we're missing work, for 5-6 days every 2-3 weeks. We can't get out of bed. It's affecting our social relationships as well.
We're missing participation in sport.
Yeah, like young girls.
Yeah.
That's one of my biggest bugbears is girls missing out on sport and the drop-off rates for that and school attendance. I mean, it's not necessarily forever, and what we do will often change and change with you as we go along. But it is okay. I think the old adage of, well, this is natural, so just put up with it, is not appropriate at all. There are a lot of things that are natural. They're not necessarily good, and we don't always put up with them. So it's the same for this. It's relevant for the relevant people at the relevant time, and we just need to be open to what are the options that I've got to me, and does this suit me at this particular time for this particular purpose? So if we come to it at that point in time and just say, well, this is not one thing for everybody, then I think you understand why it's being used for you. We're not all the same. None of us are the same. And what works for each of us is very, very different. And so having I think an open approach and understanding and a trust that, okay, yep, we're going to work through this together and we're going to step our toe in and just see, okay, what's working for you. But if that doesn't work, or if that's not okay, or if you're having problems with that, okay, we've got other options and we're going to move to this. But you've got to tell me what's going on.
It's that wayfinding approach, isn't it?
Absolutely.
Like just because that didn't work, it's not throwing it in the bin.
Absolutely.
Right.
Yes, and we were saying earlier that one of the approaches I make, or one of the ways I discuss it with my patients, is to say finding the right option here can be a bit like finding a pair of jeans that works for you. And just because you've tried the first one on and it looked terrible, and we're women here, we've all done that, haven't we? We've all tried on the horrendous pair of jeans, even though we thought it looked good.
The latest fashion, you're like, I'm going to try these on, and then you're just like,
the super hipster,
but my body shape doesn't fit this particular jean. Yeah.
And what was something that was a nightmare for my next door neighbour might be good, might be the right one for me. It might not be. And we were just saying, I mean, I'm quite tall. I'm 5'9". You're not
very, very
tall. The jeans that work for me are not going to work for you, and vice versa. And so it really has to be about very individualised approach.
Yeah,
very individualised.
And I think one of the things we talked about off air as well is I asked about these interventions through the lifespan as well. So what you might take at 17 might look different to when you're 35, 40, where you're at in life as well.
Absolutely. And so you often see that developing, and what your requirements are, whether it's endometriosis or heavy bleeding or just simply contraception or PMS symptoms that we're trying to manage, or PMDD, that is going to look different also. And there's all the other social and environmental factors that come into that. Your hormonal experience, have you had children, have you had pregnancy, breastfeeding or not? Are we going through an early menopause or perimenopause? What I would use in that space is going to be very different to what I use for someone who's 17, potentially. So what are we trying to manage at that time for you is going to be different. And so that definitely comes into it, and it won't be the same. And that also goes back to the whole idea of perhaps what you used when you were 17 and you're now coming to see me at 42. Maybe it didn't work back then, but maybe it's okay to revisit it again now. It may be very different. You're different hormonally, your body is different. Everything has changed quite dramatically in that time. So again, being open to saying, well, actually, maybe I could look at that again. If your doctor is sitting there thinking, I think actually this could be a really good fit for you, not being too closed off.
Yeah.
And I'm conscious of time, but I just want to pick up on, Alecia, you mentioned Zoli and how that's different. So I just want to make sure that we're sort of covering a few of the other things.
For sure. So, and you're right, we knew that we were trying to cover far too much today. But Zoli is one that I do like. It is one of those ones that is a body-identical estrogen, so it is different to most of the other pills, which have got ethinyl estradiol or ethyl, and it's got a different kind of progestogen in it as well. So that's nomigestrel.
Nomigestrel, yeah.
Thank you.
Yep. Haha, you didn't pronounce it.
I was like, I wish I had a list of these in front of me. Thank you, Jess. That's why you're here today as the guest. It's quite different, and in my experience, it is the least likely to cause mood disturbance than the others.
Yeah, I think, again, I think that can be tricky and depends on what stage and age you're at. So Zoli, so in particular, sort of that early perimenopause stage, I think it's very good for bleeding control, and perhaps some people who do struggle from a mood perspective on other pills. Now, that can be the progestogen and it can be a bit of the estrogen that we're using as well. They often can do well with the body identical estrogen. So going to Isoli with an estradiol. Nextstellis as an E4 is an interesting one as well, and that's most recently come onto the PBS. Which is wonderful.
Yeah.
So often we find that combination can be really good as well as the bleeding control. So particularly perimenopausal patients, if I just put my little menopause hat on for a moment, you may be getting a lot of symptoms or breakthrough symptoms on ethinyl estradiol. And you're like, I don't know, this used to work for me. I don't know why it's not working anymore. And so we do see some of those breakthrough symptoms with that. So switching to an estradiol-based pill, if you're still needing contraception, wanting the pill, the control, etc., Zoli can be a good fit in that space as well. And then you do have your ones like, Slender as well, which is drospirenone, which is different progestogen again.
Yes, different pair of genes.
Yeah, different pair of genes.
Yeah, that's probably a good segue because we haven't got to talk about the progestogen-only group of medications.
Yep.
So how do they work differently to a combined pill?
So as I said earlier, the progestogens are really what it's doing the heavy lifting in terms of contraception. Okay, so that ovulation suppression generally will, is provided through the higher dose of progestins. Okay, so the old mini pills, the old ones that we've always had forever, they don't give really good, consistent ovulation suppression. They're quite a low dose of progesterone, whereas the newer progestogen-only pill, which is drospirenone 4 milligrams, which is Slender, as an SLINDA, not the...
No, it's not Slender.
It's not the sugar substitute, no.
What's that called again?
Slender.
Slender.
Yeah.
Okay.
Yeah.
Slender.
Yeah.
Yes.
Tricky.
Yeah, it is tricky.
It's not that.
Yep.
So that does a much better job at ovulation suppression and that contraception. So it acts kind of like a combined pill.
Yes.
So those old progestogen-only ones, you had like 2 hours to take it. No one can remember that.
No.
Whereas,
hideous.
Yeah. And the combined pill, really, you've got a good amount of time, like, good 12 hours, probably 24 really, to take that pill to continue your contraceptive effect.
Yeah.
And
so who
just
should
like
be
a normal pill, just like a normal
so
combined
who should be
pill.
thinking about Slender then, and why would we go that option?
So Slender's been really great at cycle control and bleeding control. It's also for those people who perhaps are contraindicated to using a combined pill. So those who I was mentioning earlier who shouldn't be having an oral estrogen. So those who've got a migraine with aura history, VTE history, high clotting risk, we're a little bit concerned, smokers, etc. So they are okay and safe to use a progestogen-only method. And that's any progestogen-only method. But often they like the convenience of taking a pill every day. And then we haven't had a lot of options in that progestogen-only space with a pill. And so Slender's been really great at that. And you get quite good bleeding control. It's not been specifically studied in heavy menstrual bleeding patients or for pelvic pain per se, but about 48%, if we want to be exact, by about 6 to 9 months will have no bleeding, even with taking their sugar pills, which is a 4-day withdrawal bleed. They may still not get a bleed with that by that stage. So lots of irregular spotting in the first little while, which is annoying, but it'll settle down for most. But you do get really good bleeding control with that.
I almost think about, and sometimes I'll say this to patients, it almost feels like it's an oral version of the Mirena. If you stick with your Mirena's annoying for the first 8 weeks because you're spotting, but periods tend to get lighter and often disappear if you can stick with it long enough.
Yep.
Slender, often is the same idea, progesterone only, but oral. And if you can stick with it, not for everyone, but if you can stick with it, often those periods will disappear. And if you've got endo, you've got pelvic pain, removing that monthly neuroimmune trigger to your pain is bloody useful.
Yeah.
Pardon
really
the
good.
pun.
No, but it's
So the main difference with the Mirena is you're getting ovulation suppression with Slender, whereas you're not getting that with Mirena.
Yes. Yep.
So, and that's a good and a bad thing. It really depends on the person.
On what you need.
Yeah,
so I've heard it said that with the pill, with a lot of the pills, you're bleeding but not cycling.
Yep.
With the Mirena, for example, you're cycling but not bleeding.
That's
often,
right.
but not always.
Yeah.
Like everything in medicine.
Yeah.
So Slender, just going back to Slender, not the artificial sweetener that you put in your coffee. It is, although it would be useful if you could do it like that, you'd remember to take it every day. Yeah.
true that.
So drospirenone is the progestogen in Slinder.
Yep.
It is also progesterone, since we're making friends with our progestogens today. It's also the progestogen component in your Yaz and your Yasmin.
That's right.
So
Yep.
if you obviously unpack this with a experienced GP or doctor, but if you had a terrible experience on Yaz or Yasmin, I may not go for Slinder.
That's right.
That's why we want to know the history.
That's why we want to know.
Yeah,
Yep.
that's right. Before we run out of time, really important to talk about Deonagest, if we want to call Deonagest Deno.
We can do that.
Which is in Visan, which is also on the PBS for endometriosis. Tell us a bit about that one. That's a different kind of choice in my mind.
Yeah, it is. I think it's got a fairly unique position in that, I mean, obviously before it came onto the PBS most recently, it was a little bit tricky to use because it was so expensive. It's a really good progestogen in terms of bleeding control, and also tends to have a higher affinity for the prostaglandins, for the progesterone receptor. So the main issue with Visan is that it is not contraceptive but may affect your fertility. Okay, so that really means, that it's not been studied specifically around contraception. So it's sort of a bit of an adjunct or for somebody who's not needing contraception, but can be very, very good for management of bleeding, pelvic pain, and particularly endometriosis. So it does have a particular space in there, and we'll sometimes use it, as I'm sure you do, Alecia, with the addition of, say, a Marina or something like that, where we do want a bit more cycle suppression, or we just need a bit better bleeding control because we're still getting a lot of annoying spotting, that sort of thing. So you can use it as an adjunct in that way.
Yeah, so we can't trust it for contraception.
No.
But important to pick up on that it affects your fertility. Unpack that for us. So what does that mean for someone?
So that just means it's possibly causing some cycle suppression and ovulation suppression like a contraceptive pill.
Yes.
So if you are trying to fall pregnant, probably don't be using Visan.
No.
But we haven't got the studies and the published data to say, yes, this is completely safe and this is the, Pearl Index for contraception, which is a measure of how effective it is for contraception. We don't have that data on Visan.
So we can't trust it for contraception.
No.
How long after stopping Visan would you be good to go if you wanted to start trying for pregnancy?
I think with any of the pills in general, look, from a contraceptive point of view, we know you can ovulate pretty quickly. Okay, so that's the first thing. So one, if you are stopping a pill because you are having issues with it, just be aware that you can ovulate very, very quickly within a few days after ceasing that. Okay, so if you don't want to fall pregnant, you must use barrier contraception. If you are planning for pregnancy and wanting to try, again, you have a withdrawal bleed once you stop, generally speaking, within a day or two most of the time. And so you have that withdrawal bleed and then you can ovulate, pretty quickly. Now, some people will do that within that first cycle, within that first, few weeks. Others, they may have had really good suppression of their ovulation with the contraceptive pill that they've been using or the form that they've been using. So it may take them a couple more months. But in general, you could have that withdrawal bleed, have a cycle and then try, straight after that.
Because there are some concerns around, will I ever get my cycle back?
Yeah, and I think that the key to understand here is that if we're using the pill to manage a condition, so we are managing that condition. We're not saying we're taking it away. We are managing it, but that condition still exists.
Yeah.
And so when we take the pill away that we've been using to manage that condition, the underlying condition sort of just shows itself up. So that might be that actually I've been on the pill for 12 years just for contraception when I was, 16, 17. And then I'm now coming off of it because I'm thinking of trying for pregnancy, but I've never been off of it before. And actually I've got PCOS and I didn't know, that's not the pill causing that condition. That condition is there. It's been managed with the pill in the meantime. So it's not a cause from the pill per se, but it is a concern. It's like, okay, well, now I don't have a period. So some do get really good suppression. They do take a little bit longer. So say someone like using depot injection, for example, we know that causes really good suppression. So it can be, really effective contraception, but it can also take a lot of time for that suppression of the hormonal access from the brain down to the ovaries to lift.
Yes.
And so it's for that natural cycle to kick back in.
And that's the old sort of injectable contraception, which we don't use very much anymore. I mean, it's still
got its place.
It's still got its place, but it's not for everybody. But I think really important take-home message, if you're on any of the modern pills or any of the pills really, yes, your ovaries asleep within a month and often less of coming off of that, ovaries are back awake again, and that cycle is doing whatever it would have been doing underneath that when it was asleep. So the idea that I won't get my cycle back, total myth.
Total myth.
Myth busted.
Myth busted.
Yeah.
Yeah.
Dr. Jess Floreani, so many places we could go with this. Must get you back if you can.
We need you back.
Yeah, we need to do part 2, getting a pill, I think, and also if we need to talk to you about Marina as well. Important, important to have some good quality information on this in the sea of just unhelpful information. So someone at home who's got pelvic pain can have a bit of agency to really understand where they've been, what they've had, if something didn't work, perhaps why, and what might be a good choice for next time. Of course, you don't have to do all that by yourself, but
absolutely not.
But yeah, so much to unpack. So anything you want to leave us with, any couple take-home messages you just wish that someone at home with pelvic pain
I think
needs to know?
Understanding what's worked for you in the past and what hasn't, and knowing what you were prescribed is really important. That's important for someone, going to a new clinician or going to see somebody. So understand that. You don't need to understand all the ins and outs of it. Just be able to give names and details. And the other thing I think is to be open to either trying something different or retrying something that's hormonal. That there is a reason for that. It's not all the Band-Aid measure. It is part of an overall approach to managing your pelvic pain, and a really important one at that. And so being open to working with somebody around what might work for you. And it may take a few goes. And we get that that's hard. But if you're willing to go along with us, then, we really want to find the right fit for you.
And hopefully we've given people some information to be able to ask the right questions, because sometimes we don't know what we don't know. So now at least we've got some information that we can go to our GP with.
Yeah.
Thank you so much, Jess.
Yes, thank you so much for your time.
Thanks for having me.